Once Newton said, I could see farther because I was standing on the shoulders of the giants. The speakers that preceded, Jim Forrester, could see farther because they were standing on Jim's shoulders. Jim is a giant in cardiology. As I welcome Jim to give this talk, I would appreciate if audience stands and applaud Jim. Jim, it's an honor to have you. All yours.
Well, thank you for that lovely introduction, Rich. Well, I'm going to tell you in the next half hour one of the most remarkable stories of our lifetime, and it has to do with your profession. It is the story of how cardiology evolved from bedside medicine to the modern cardiology technology explosion. It's a truly remarkable set of events. Now, it begins about a half century ago with the discovery of antibiotics during World War II, penicillin. And at that time, then, heart disease emerged as our #1 killer as infectious disease faded away. But as our soldiers returned from World War II, we had no heart surgery, no defibrillators, no pacemakers, very few drugs, no coronary care unit, and therefore no effective treatment for congenital heart disease, valvular heart disease, or coronary heart disease. We were like this iconic Norman Rockwell painting, being the cardiologist here examining the doll. We were nice, but we had not much to offer medically. And so our story begins with this man in the upper left-hand corner, Dwight Harkin, an Iowa farm boy who had gone to Harvard and at the age of 33 or 34, was assigned during World War II to London Heart Hospital's 160th Battlefield Hospital, where he, for the first time, saw things that he had never seen before. Bombs from above, fire on the ground, and in his thoracic operating suite, shrapnel protruding from the hearts of soldiers with their chests blown apart. Now, Harkin faced an inescapable and almost unsolvable conundrum, a dilemma. That is, he could leave that shrapnel in which case that metal inside the heart cavity would serve as a nidus for bacterial endocarditis, and at that time there was no therapy as yet for bacterial endocarditis. Or he could put a hemostat on that shrapnel and yank it out, in which case he faced exsanguination. And booming down through the century, or the half century, from Vienna came the voice of Theodor Billroth, the great Viennese surgeon at the turn of the 20th century, who said, "A surgeon who tries to suture a heart wound deserves to lose the esteem of his colleagues." And from England, the great English surgeon put a final exclamation point on this idea: surgery of the heart has reached the limits set by nature. No new method and no new discovery can overcome the difficulties that attend a wound of the heart. And yet, Harkin went ahead. He put a hemostat on that shrapnel and he yanked. He encircled the shrapnel first with a purse string suture and then pulled it out. And here from a letter he wrote to his wife that night, I want you to think of yourself as Dwight Harkin putting that hemostat on and taking that action. Then suddenly with a pop, as if a champagne cork had been drawn, the fragment jumped out of the ventricle, forced by the pressure within the chamber. Blood poured out in a torrent. I put my finger over the awful leak. The torrent slowed, stopped, and with my finger in situ, I took large needles wedged with silk and began passing them through the heart muscle wall, under my finger and out the other side. With 4 of these in, I slowly removed my finger as one after the another was tied. The blood pressure did drop, but the only moment of panic was when we discovered that one suture had gone through the glove of the finger that had stemmed the flood. I was sutured to the wall of the heart. We cut the glove and I got loose. Well, I knew Dwight Harkin at Harvard many years later when I was in training there. He was a redhead, a fiery tempered guy who would throw things in the operate, terribly intimidating guy. And then subsequently I got to know him from the podium at meetings like this, where he was the most charming raconteur that you could ever meet at a speaker's dinner. In fact, when I was at Harvard, we used to call, whenever he would express himself, he'd get very red in the face, so we called him the Great Red Man, behind his back, of course. And we said that with regard to this glove getting stuck to the heart, that he could have just as easily cut off the end of his finger and left it there and he would have got the same result. So that was us talking about Dwight behind his back. But Dwight Harkin's moment, that moment, completely overturned current wisdom, as you can imagine. And when he then went to finger fracture of mitral stenosis using that same purse string suture, but now sticking his finger into the left atrium, and that succeeded, an entirely new question arose, and that was, could surgeons operate on a non-beating heart? And that brings us to this man, also a post-war or intra-war surgeon, Walt LilyHi, C. Walton LilyHi. He was another headstrong guy who did things the way he wanted to. And he came up with a flash of intuition, which was, if the mother's body could support a fetus, why couldn't it support the body of a child with an arrested heart while he was operating and the body was outside the uterus? Wow. Well, it was called cross-circulation, and the idea was basically connect the parent to the child, and then you could open the heart and operate. And when he proposed that, it put him in direct opposition to the highly principled chief of medicine at the University of Minnesota Hospital, whose name was Cecil Watson. And Watson famously said, for the first time in history, a surgeon may have a 200% mortality. Not only the patient being operated on, of course, but the parent as well. Now, Walt LilyHi was a fascinating guy to me. He had lymphosarcoma on the last day of his surgical residence. He had a dissection. It was lymphosarcoma of the parotid gland, dissected down into the mediastinum, and was given a projected 5% 5-year survival. He was a man who ignored social norms. He cared not the least about what other people thought. He was a very nice, wonderful sense of humor and a very good surgeon in-house. Outside, he was a carouser and lived a life of sin. So LilyHi, anyway, defied Watson, and he went ahead and did the surgery, and he was successful. And then, ignoring the era's strict ethics on self-promotion, at that time it was absolutely verboten to advertise for yourself. He called a press conference. He had charts that he handed out and figures and so forth. And then he threw open the auditorium doors and he brought in this parent and child who, Pamela Schmidt was her name, and she just overwhelmed the audience of people who were there. Reporters realized they were seeing a sentinel moment in their writing career, and they reported it as such. The New York Times reported impossible surgery now done, and LilyHi triumphed, and Watson's eyes bored into the back of his into his back as he accepted plaudits. But within that year, in December, one of his patients suffered an air embolus, and it was the parent of the child. It was a 34-year-old woman named Geraldine Thompson, and she became unable to take care of her children. And at that moment, essentially, in the minds of cardiac surgeons, cross-circulation died. It was one of the most embarrassing moments I've ever seen in cardiology. When LilyHi was presenting his results at a national meeting, somebody from the back yelled, "Admit you have a vegetable in the hospital," and of course, it was true. And that then leads us to the incredible story of John Gibbon and his heart-lung machine, which was the first great breakthrough in cardiovascular technology. John Gibbon was a Philadelphia patrician, wealthy. He was the fifth in line of cardiac surgeon of surgeons in his family. While he was at Mass General, he began to do research on trying to develop a heart-lung machine, and he essentially was unsuccessful, working and working and working over a 22-year period, until through his social contacts in Philadelphia, because he went into the highest society, he met the president and CEO of IBM, whose name was Thomas Watson, and Watson assigned 5 IBM engineers to work with him in Philadelphia, and they solved the problem of oxygenation, which was the central reason that it had been impossible to develop a heart-lung machine. And in so doing, then, he created this device that you see on the right, and performed the first successful open heart surgery on with a heart-lung machine. It took him 26 minutes to close an ASD, which Walt LilyHi, a very skilled surgeon, had been able to close in just 6 minutes when he used cross-circulation. Gibbon was not a great surgeon, and in any case, amazingly enough, at age 49, at the peak of his career, the pinnacle of his achievement, he used that heart-lung machine only 4 times. His other 3 patients died. They were all children, and he quit. He just stopped doing it and called a moratorium and never did another surgery with it. But his device opened the door just a little bit, and beyond that open door, someone saw the incandescent light shining beyond it, the promise. And that person was Al Starr, who was only, think of yourself now, he was only 32 when he moved from New York to the University of Oregon to be the chief of cardiac surgery there, and his assignment was to develop a cardiac surgery, budding cardiac surgery program. And he met with the older man that you see in this picture, whose name is Lowell Edwards. He had Parkinson's disease at the time. He was a very inventive man, and together they created this valve, a very clever valve. It was a ball in socket, or a ball in cage, I should say, ball in cage device that was the Starr-Edwards valve. I got to know Al Starr through my own mentor, Jeremy Swan, because both of them were consultants to Edwards Laboratories. And I saw Al Starr last year at the ACC. He is meetings. He's now 88 years old. In the last year, there were 200,000 surgeries performed of valve surgeries. The advance from Al Starr's moment of success some years back in the early 60s. And the future, as you heard from Raj and from Saibal, remains as fantastic as it was at the moment that Al Starr invented that ball in cage device. Now here's the fascinating thing for Mike Shahata and for Sumit and our other EP guys here, is that it was the complications of heart surgery that created your subspecialty. The cardiac surgeons are responsible. In Cleveland, this man, Claude Beck, another highly innovative iconoclast, was operating on a 14-year-old boy with pectus excavatum when, as he was closing the chest, the young man developed ventricular fibrillation. At that point in time, that meant the end of the surgery. It was sure death because there was no treatment for ventricular fibrillation at all. But he knew that in a nearby laboratory was a world-famous cardiac electrophysiologist named Carl Wiggers, and Wiggers had begun to work on trying to defibrillate dogs, and he had developed a device. And so Beck demanded that Wiggers' device be brought to his operating room, and for 45 minutes he stood in the operating room squeezing this young man's heart until they brought the device in. He got the paddles, wiped them off, of course, you don't want the kid to get an infection, and he applied the paddles, and it worked. He defibrillated the young man, and in that moment, mankind's dream, first expressed by Lazarus in the Bible, return from death, was first realized. And Beck's experience then led to the development of cardiac defibrillators. Now, there is one of the very earliest ones, and later Beck did something further. He had a physician patient who had a sudden cardiac arrest in the outpatient area, and he went in and slashed right through the man's shirt and between the ribs, reached in, began squeezing the heart, and had the defibrillator brought, and they defibrillated that man. And from then what happened was that Beck said every surgery resident in my training program must have a scalpel in his pocket and do the same thing whenever there's an arrest on the ward. And we had, for a period, I would say 5 years, surgeons walking around with scalpels in their pocket. And Chief of Cardiology at Hopkins, Richard Ross, used to like to tell the story that he fainted once, and he looked up, and here was the cardiac surgeon. And I said, well, heck, Richard, you know, the same thing happened to me when I was having a turf battle with Jack Matloff over, certain things with the cardiac surgeons. And I looked up, and I hadn't even fainted when I had. So, now, the fascinating thing about Walt LilyHi, who was surely one of our greatest of all ever surgeons, is the great tragedy that evolved from his personality, his great strength, which was his independence from being concerned with what everybody or anybody thought, became his Achilles heel, his tragic weakness. He didn't file income tax reports for 2 years. The IRS contacted him and said, okay, I'll file. And then for the next 3 years, he didn't file again. Now that tends to get the IRS irritated if you're not aware of it. So they decided that they would make Walt LilyHi a showcase because he was a world-famous cardiac surgeon. And they found that when they investigated that he had failed to declare $250,000 of income from some 318 patients. He had taken some questionable business deductions. He had taken his parents' anniversary party and deducted it as a business expense. He had a Las Vegas prostitute deducted as a secretarial expense, and they brought her in, and she testified that that really was not her major strength then to top it all off, they did forensics on the little cards that he kept his records on. It turned out that it had been gone over a second time in ink, and the numbers had been changed, and they showed that the ink was different. So beyond failure to report, he was now accused of fraud. And he was then, by the jury, convicted on all 5 counts. He was fined. The judge faced a conundrum because here was this brilliant, iconoclastic individual. He gave him no jail time, I think probably because he realized that Walt LilyHi's punishment was what followed, which was he was completely ostracized from his own society. He was forced to step down at New York Hospital Cornell, where he was chief of surgery. He returned back to Minnesota, which was his home. He was made unwelcome at the university. When he went to the country club, people would come if they were sitting at a table like this and talk to his beautiful wife, Kay, and absolutely ignore him. His Minnesota medical license was revoked, and of course, visiting professorships and wonderful things like I am here to do today, give a lecture, were all taken away from him. And so that was the story about Walt LilyHi, but it wasn't the end of the story. This is Walt, by the way, the picture. Remember that he had the surgery on his neck, and so his head was always tilted over a little bit after some years because of the scarring from the parotid surgery, and he was bald. And so he always reminded me of E.T., and I think you can see that right there in Walt's picture. But the most poignant moment in all of American cardiology, to me, happened about 8 years later when the man in the bottom left, John Kirkland, who was his great competitor at the Mayo Clinic, he was the Mayo Clinic's lead cardiac surgeon, had now been elected president of the American Society of Thoracic Surgery, and he was giving his inaugural speech when he spotted Walt LilyHi in the audience, and he said this. He pointed to Walt LilyHi and he said, "He was and still is a great hero of mine, one of cardiac surgery's greatest innovators. Dear colleagues, may I depart from my text to ask that this pioneering surgeon stand to your applause. Walt LilyHi, may we see you." And Walt LilyHi stood to the applause of 1,000 hands, and he was in effect professionally redeemed. He subsequently became the medical director of St. Jude's and went on to die at 80 from pneumonia. But what a fascinating career of highs and lows of all the people that I have known in all my years in cardiology. He would rank #1. And that leads us to medicine's, not cardiology's, medicine's strangest story of all. This guy, 24-year-old Werner Forssmann, in 1929, in a little town called Eberswald, about about an hour's drive northeast of Berlin, came up with the idea that he would pass a tube into the heart of a patient so that he could more directly deliver medications, and that would be of benefit to the patient. And so he went to his chief, and the chief of medicine gave him a very Teutonic absolute refusal. You may not do that. And so he pretended that he accepted that verdict, but instead he went to Nurse Gerda Ditzen and romanced her to participate in his scheme. And over a period of a couple of weeks, he got her to unlock the cabinet. She was a very key person since she had the key to the supply cabinet. And then together they went, and he took her to a remote room in the hospital where she lay down. He strapped her down, and then he cathed himself. And together they walked to the basement X-ray unit with this thing dangling from his arm like some snake in a sci-fi movie. And he got an X-ray to prove it. This is the X-ray that he got at that time to prove. You can see that he claimed it was in the ventricle. I think it's pretty clearly not in the ventricles, in the right atrium, but he'll get credit anyway. And people said that man is crazy, and he was denied cardiology post throughout Germany. And so he stopped and went into urology, and that was the end of it. Except that he published in Germany's leading internal medicine journal what he had done. And in the United States, toward the at the end of the 1930s, the beginning of the 1940s, a couple of doctors of Cournand and Richards began using that technique and took it to World War II young men who were in shock on the battlefield and used it for monitoring volume and pressures. And that was the emergence of cardiac catheterization when they used it in soldiers in cardiogenic shock. In 1956, Werner Forssmann, Cournand, and Richards were awarded the Nobel Prize in Physiology, and people who, when they saw that Werner Forssmann had won, harped that he was the least intelligent person to ever win a Nobel Prize. But if he was, he surely was the most daring also, was he not? So that leads us to the second great paradigm shift in cardiology. The first was clearly Dwight Harkin and that moment of putting the hemostat on the shrapnel. And that second great paradigm shift, which completely switched around thinking, and that's what a paradigm shift is, came with this man, Mason Soanes. He was, in those years, Reader's Digest had a feature called The Most Unforgettable Character I Ever Met. Had I been asked to write, this would have been the guy that I wrote about. He was an absolute sartorial disaster. He was a short, kind of chubby guy with glasses, and he walked around in a scrub suit or a t-shirt, and usually had a little spot of blood someplace on them. And when I was invited to be a visiting professor there at Cleveland Clinic, he was just irrepressible. He would walk from place to place. He was delighted in shocking people. And in the cath lab, he kept a lit cigarette in a hemostat so that he could take a puff between injections of dye. He was a chain smoker. And so that was the state of early cardiac catheterization. Well, one day he was doing a routine, at that time a routine coronary aortic root angiogram, and when he power injected, the tip of the catheter flipped like a garden hose right into the right coronary artery orifice, and he delivered 30 cc's of contrast material with power into the right coronary artery over a period of maybe 2 or 3 seconds. And conventional wisdom had decreed at that time that this would be fatal, that simply you could not inject contrast material into a coronary artery because it didn't have any oxygen, it would sludge up or whatever. And Soanes stood there stunned as the heart did stop. And then after a few seconds, as we all know, since Seibald does this all the time and he hasn't been arrested, it started up again. And Soanes realized that he had witnessed the first selective coronary angiogram. And what did he do? He walked back to his office and he bellowed to anybody who would hear, "I just revolutionized cardiology." And allegedly his secretary, Elaine Caton, looked up from her typing and said, "Again?" So that was Mason Soanes. There's more stories. You could spend the entire day at the podium telling Mason Soanes stories. But this was truly a paradigm shift, but of course its limitation was that angiography for the first time showed us the disease in living people, but it didn't tell us anything about how to treat it. And yet, 8 years later, it did, because Soanes worked with this man, René Favaloro, who was born and raised in the Pampas. He was a very bright man. He was #1 in his class in Buenos Aires, and was not given the plum job that always went to the #1 student. He was exiled by the government because of his opposition to the Juan Perón regime, and sent to rural practice for 10 years or more. He always wanted to do something more for the world, and so at age 39 he quit his practice and came to the United States with limited English capability and no money, and found his way to the Cleveland Clinic, where he got a job as a lab tech in the cardiac surgery department. He was so skilled that he, amazingly enough, subsequently got a cardiac surgery fellowship with Donald Effler. And he studied angiograms with Mason Soanes at night. He was, interestingly to me, the most focused on moral principles of anybody any cardiologist or cardiac surgeons that I've met in my career. He was a humble man who always considered himself a country doctor. And in 1967, he relieved angina in a patient by doing the first coronary bypass surgery. Over the next 3 years, he did over 1,000 in established bypass surgery. He was offered, he decided he had to go back to his own country because that was just part of his personality. He returned to Argentina to create the Fundación Favaloro, which you see pictured here. He was tremendously proud of this because it treated the wealthy and the poor equally. And it fell into terrible debt during Argentina's economic collapse in 2000. He wrote to the president of the country and said, you cannot let this happen, and he was essentially ignored 7 letters that he wrote. And on a Sunday morning in 2000, he walked into his bathroom and symbolically shot himself through the heart in protest. A tragic story for cardiology and for Argentina. Now, the technology that triggered these advances in surgery ultimately made its way into our field, and they came together at that time in a way that nobody could anticipate. 4 technologies: defibrillator, pacemaker, CPR, and the balloon catheter merged. And the first coronary care unit was established in 1962. Everybody had a CCU by the end of the decade. This is the Jeremy Swan and Willie Gans, after whom the catheter was named, and I was fortunate enough to publish the article that described hemodynamic therapy of myocardial infarction in a 2-part article in the New England Journal that subsequently became called the Forrester classification. You actually saw it in one of the slides earlier today. The third great paradigm shift came from this man, who deserves particular mention because he pursued his vision despite the fact that he faced widespread scorn for years. He is Andreas Grunzig. He was a truly charismatic, handsome guy. One of his nurses described him as a cross between Errol Flynn and Clark Gable, to get you a sense of, if you remember those faces from that time. He was that alluring. I had dinner with him very early in his course, before he actually came to the United States, and I walked away thinking, this guy has charisma and he's going to become a famous man, interestingly enough. His vision was that he could force open coronary artery stenoses by putting a bladder on the tip of a catheter and then inflating it. It took him, he worked in his kitchen. This is a picture, the second one, of his stuff in his kitchen. He took him 3 years to create just that catheter, and he then tested it in animals and brought it to the American Heart Association in 1976. There he is. He was essentially scorned by his bosses in Zurich and then ignored by the cardiologists at the American Heart Association. And so he went back and did angioplasty on the man on the far right, Adolf Bachmann, who's still alive today. And he returned the next year at something that I've never seen before or since, when he presented his patient angiograms, which were dramatic. There was applause during his presentation, and at the end of his presentation, the entire audience stood, and he got a standing ovation for what he showed, which was complete relief of coronary stenosis by balloon angioplasty. He was recruited to Emory. We tried to recruit him to Cedars unsuccessfully. There you could wonder as to whether he became a modern Icarus. He divorced his wife, Michaela, whom I had met at dinner some years before, and married this very attractive medical student, Marianne Thornton. He bought a spectacular mansion in Atlanta, where he staged lavish parties following his training courses. He bought himself a private plane, learned to fly, and bought a cottage on Sea Island, about an hour's flight south of Atlanta. And he decided, after being there on one weekend, to fly back during Hurricane Juan in 1985. And while flying home from Sea Island during Hurricane Juan, he crashed in a Georgia field at 300 miles an hour, completely disoriented. And he and his wife died. The only thing left really was just the tail of the plane with the inscription AM 385, Andreas and Margaret married in 385. So in the decade post-Grunzig, we did 300,000 angioplasties in a single year, which surpassed the number of bypass surgeries. And from that, the cath lab emerged as the hub of cardiac diagnosis and therapy for all kinds of things, way beyond just coronary angioplasty, as you have seen at this conference today. The breakthrough to prevention of coronary disease our final person in this past scenario is this man who was the champion of dogged persistence. Akira Endo, he was a biochemist at Sankyo in Tokyo. And can you imagine doing this? He decided that fungi must have something that inhibited cholesterol synthesis because fungi had the capacity to kill insects that landed on them. And so he screened, he made extracts of these fungi, liquid extracts, and screened a different fungus over a period of 2 years. He had 6,000 fungi extracts that he tested, about 10 a day. And he had liver membranes that would synthesize cholesterol. And from those tests over a 2-year period, he found 2 cholesterol synthesis inhibitors out of 6,000, doing the same thing every day. It was considered irrelevant, his research, and he was essentially fired by Sankyo. He was told that he was no longer necessary there. And I will not tell you his whole story, but it took 18 years over for this then to emerge. It turns out that he had indeed discovered statins. And nobody recognized it for a while until ultimately Merck got the patent for it, and the first clinical trial with a statin was simvastatin, and it resulted in a 42% reduction in mortality in that first group, and that was the beginning of the randomized trial area and our own wonder drug in cardiology. Akira Endo is still alive today. I tried to invite him to Cedars to lecture this year, but I was not able to get him to come. So let's go. My talk deals with the past and the present. I want you to see and contemplate what has happened in this period in my lifetime of cardiology, not just my lifetime in cardiology. Here is, on the left is the Beck's defibrillator. In the middle is Paul Zoll's pacemaker. The first pacemaker you had to push around like we saw now with the circulatory assist device. The same thing was true for the pacemaker. And right now in Europe, not yet in Los Angeles or in the United States, that little thing you see pinched between that man's fingers is a cardiac pacemaker. It's about the size of a grain of rice. So that is what has happened in electrophysiology. How about heart failure? There's the catheter that I used back in the late 60s and early 70s. That's evolved now to the middle, which is an implantable device that you essentially embolize into the pulmonary artery. Just sits there and tells you the wedge pressure for as long as you want to measure it. And on the far right is an invention by our own Cedars-Sinai's Neil Eigler, which is an implantable manometer that you pass into the left atrium. And these devices, the two on the right, have been shown now to reduce hospitalizations by about 30%, repeat hospitalizations in people with class 3 heart failure. Tremendous potential advance in the treatment of heart failure, not necessarily for prolonging life, as we learned in one of the previous talks, but for keeping people out of the hospital and reducing the cost of medical care. What about management of valve disease? There on the right is the finger fracture device that Dwight Harkin used to poke through the purse string suture in the left atrium, stick his finger in there, and root around in the mitral valve like this with his finger to separate mitral stenosis, the first successful treatment of mitral stenosis. You saw from Raj Tavor and from Seibel, the mitral clip, and if you read this week's Journal of the American College of Cardiology, you saw that the first report that I've seen of mitral valve replacement, not in an existing not in a one that had a prior mitral valve in it, but a native mitral valve. 2 patients who have successfully had mitral valve placement through a transapical approach. This is clearly the future of cardiac surgery, and I feel confident that in the years to come, that's the way we're going to be doing cardiac surgery, is through percutaneous approaches. Which ones will succeed, of course, remains to be seen. But the mitral valve is now also a candidate. It's much more difficult procedure technically. And what about Akira Endo in his little lab next to a Tokyo subway station? Now we have PCSK9 inhibitors, which produce in one of the trials a 72% reduction in cholesterol. Think of what this means. It means that every one of your patients could, if you so desired, were willing to use statin therapy and then add a PCSK9 inhibitor to it. If this works out, this is the future, every one of your patients could have a normal LDL into the range that we think is normal, 50 to 70 milligrams per deciliter, almost independent of what they start with. That could be the end of coronary disease, if indeed coronary disease is dominated by the deposition of cholesterol in the coronary arteries. So, the greatest scientific achievement of the time that I am speaking of, our golden age of cardiology certainly deserves determination. We had valve surgery, cardiac transplantation, which I didn't discuss, bypass surgery, defibrillators, pacemakers, coronary angiography, coronary care units, interventional cardiology, statins, percutaneous valve replacement. And how does that stand up against the other great advances of that time? Well, there was the Manhattan Project, in which brilliant men collaborated and hastened the end of World War II by developing the atomic bomb. Its legacy has been massive suffering and insoluble politics. Landing on the moon was heralded. It was the dream of many millennia. Government has withdrawn from space flight. In cardiology's golden age, restoration of life for millions, relief of suffering for millions, and we are poised to conquer the scourge of the 20th century. Surely genetics will stand one day as perhaps our greatest advance, but we are definitely in the running. So I would remind you of the wonderful phrase from Ecclesiastes, which says, the race is not always to the swift, nor battle to the strong, nor riches to men of wisdom, nor favor to men of skill, but time and chance happens to us all. We were common men in an uncommon, and women in an uncommon time. And I have written all this in a book called The Heart Healers, which will come out perhaps in autumn of next year. I hope you will take a look at it. Thanks so much for having me up here.